Welcome back, everyone, to another engrossing episode of MRCS Masterminds, where we arm you with the in-depth knowledge and clinical insights you need to excel in your MRCS examinations and beyond. Today's episode is an extensive one. We're covering complex electrolyte and acid-base imbalances, a subject that we can't emphasize enough for both your clinical practice and your exams.
Absolutely. I second that. It's not just for the MRCS exams. This topic is integral to daily clinical practice. We've got an intense and educational episode today. We're going to dissect a hypothetical clinical case and delve deep into conditions like hypokalemia, hypochloremia, metabolic alkalosis, and more. We'll frame this discussion within the care of critically ill surgical patients, or CCrISP protocol.
Couldn't agree more. The CRISP protocol provides invaluable guidance for managing critically ill surgical patients, so understanding it is pivotal for MRCS aspirants. Now let's set the scene with our clinical case.
Indeed, so picture this. A 58-year-old woman is rushed into the ER. She has a history of persistent non-bilious vomiting. Lab tests reveal hypokalemia, hypochloremia, and metabolic alkalosis. If you're a clinician or preparing for the MRCS, this scenario should make you sit up and pay attention. Multiple red flags right there.
Absolutely. So where do we start? How about acid-base balance, which is clearly disturbed in our patient? Metabolic alkalosis is the indication here, suggesting that the patient has been losing acidic ions, possibly through persistent vomiting. While one's first instinct might be to correct this imbalance immediately, it's crucial to step back and think. What are the protocols, especially according to the CRISP guidelines?
You're hitting the nail on the head. According to the CRISP protocol, before administering treatment, ruling out secondary causes is crucial. These could include diuretic misuse, mineral or corticoid excess, among other conditions. And as the protocol stipulates, we shouldn't merely focus on the pH levels, but also aim to treat the root cause of this alkalosis.
Absolutely. Let's now shift our focus to hypokalemia. Now, in terms of the pathophysiology behind hypokalemia, we're looking at a situation where there's a massive loss of potassium, which in our patient is due to persistent vomiting. The CRISP protocol advises immediate identification and careful management, which is not just about potassium replacement. Would you care to elaborate?
Of course, while potassium replacement is pivotal, it's not enough. The CCrISP protocol suggests continuous ECG monitoring to manage the potential risk of cardiac arrhythmias. Also, remember that other forms of electrolyte imbalances, such as calcium and magnesium imbalances, can further complicate the situation.
Excellent points. Moving on, let's talk about SIADH, a less apparent but highly relevant consideration in our clinical scenario. SIADH, or syndrome of inappropriate antidiuretic hormone secretion, can often masquerade behind a range of symptoms and needs to be explicitly identified for proper management.
Exactly. SIADH could be the reason behind euvolemic hyponatremia in our patient. Management would involve fluid restriction, diuretics, and potentially even hypertonic saline, albeit under stringent monitoring. And if SIADH is confirmed, identifying and treating the underlying etiology, which can range from malignancies to medications, is also crucial.
Right, now let's discuss hyponatremia in a broader sense, which is also a significant issue in our hypothetical patient. When it comes to hyponatremia, the CCrISP protocol provides an effective framework for identification and management, focusing on assessing the volume status of the patient. Would you like to elaborate on the management strategies here?
Certainly. Management has to be patient-specific. It's not a one-size-fits-all kind of deal. The CRISP protocol emphasizes this and suggests either administering hypertonic saline or diuretics based on the clinical scenario. Monitoring is key to avoiding complications such as central pontine myelinolysis. The protocol outlines that regular checks and rechecks of sodium levels are a must.
Absolutely. It's important to understand that these electrolyte imbalances and acid-base disorders can precipitate severe complications like metabolic encephalopathy and cardiovascular dysfunction. Therefore, following protocols like CCrISP, particularly when managing critically ill surgical patients, can be life-saving.
Well, that was quite an intense discussion. For those preparing for MRCS, we recommend revising this topic thoroughly, with particular attention to CCrISP protocols. They are frequently the subject of case-based questions.
Before we sign off, for those wanting to dive deeper, we suggest the following references. Care of the Critically Ill Surgical Patient by the Royal College of Surgeons. Fluid, Electrolyte and Acid-Base Physiology, a problem-based approach, by Camel and Halperin.
Don't forget to subscribe, rate, and review our podcast so you don't miss our upcoming episodes.
This is a journey, and we're committed to making it as educational as possible for you. Thanks for tuning in to MRCS Masterminds. Until next time, good luck with your exams and your clinical practice.